you're struggling with a knee extension post ACL surgery, you're not alone, and in fact it's the biggest problem I see in my clinic. In today's video I'm going to show you what I do before I send somebody off to a surgeon or for an MRI scan, because let me let you into probably the biggest secret. Half the time when somebody has an extension issue, it's not what most people think. It's not scar tissue, it's actually really bad rehab. So the first thing we're going to address is the most common mistakes I need you to avoid doing after ACL surgery. And the biggest mistake people often make is using things like a wedge pillow, or when you're resting, you actually rest with the knee like this with cushions underneath it. I've had 4 knee surgeries myself. I know exactly how it feels to lay with your leg straight, and I know how comfortable it also feels to lay with a cushion under your knee. But trust me, that will inhibit and delay and slow your recovery down. Second mistake, people don't do the right exercises. You focus on flexion, getting the knee to bend, getting the knee to bend. You think walking with crutches, I need my knee to bend, then everything will be fine. If I can bend my knee, I can squat, right? Well, I can understand why you would think that, and especially if you don't have a therapist or a proper plan that's telling you not to think that. So not doing the right exercises. And then the third most common thing is actually not doing enough of the exercises to the right intent, because newsflash, 5 reps of towel squashes twice a day is never going to get your knee straight, okay? So that's the common reasons that I see. And then if we look to address why it's so important, because we can't make a video like this and not address why you actually need knee extension, because it wouldn't make sense. And some of you often just don't recognize that you need full knee extension, right? Why would you? But let me tell you something, you can't walk, you can't come off crutches if your knee isn't straight. You can't get back in the gym if you can't get a straight leg raise. It just won't work. You can't run, you can't return to sport, because all of the criteria is based on having a straight leg, as well as other proper testing that you'll find actually in my complete ACL recovery guide. Let's get on, because this demo leg is actually costing me £20 an hour. I'm going to try to cover this video for therapists and patients alone, because I really am that tight. I'm tight on time and I'm tight on money. So let's get into it. When and what am I going to panic about when a patient comes into my clinic with their knee in fixed flexion? First things first, which I really want to get out there, my patients that have seen me pre-surgery, like Matt, post-surgery, they know exactly what they're doing and when to do it. They don't come to my clinic with their knee like this. It just doesn't happen. Because on day 1 of surgery, they wake up and they're squeezing their quad, because I tell them, listen, your surgeon, last thing he'll do is get your knee straight, and then he'll also bend it right in. Job done. That's the last thing they do, is check your range of motion. So you've got it, and it's our job to actually keep it. So the first thing when it comes to knee extension is setting those expectations. And this is why none of my patients arrive in clinic with a fixed flexed knee, because they're all ready and they know what to do and when to do it. But if a patient arrives in my clinic, there's a timeline that I'm going to start to panic. If they're 2 weeks post and they don't have full extension, I'm going to think, okay, we can work with that. That's fine. And we'll do a range of drills to get extension back. But you get to 4 weeks onwards, that's when I really start to worry, because you have already built up quite a lot of bad habits. And if you're 3 months, 4 months, 5 months, 6 months post-op and you don't have knee extension, the worst thing about that is that we're going to have to go backwards. Because you've probably started running because your therapist has told you it's okay. They've not got a proper ACL criteria that they've checked. Something again like the ACL recovery guide that tells you the strength testing, the pre-running drills, everything that you need to do, and what will gatekeep you and stop you from doing the things that you can't do because you haven't passed the correct criteria. But let's say, for example's sake, for this video, a patient comes into my clinic, let's say 4 months post-op, and they've got around about 10 to 15 degrees of fixed knee flexion. First thing I'm going to do is understand what surgery have they had, why isn't their knee straight, what have they actually been doing. So I'll say to them, show me what you've been doing, and they'll often show me the exercises, and their quad won't be active, it'll just be quivering. The patella just relaxed, the knee is normally really quite stiff, and 9 times out of 10 they say I do my exercises twice a day. I've got a sheet of exercises, just do a few squeezes and it just won't go straight, Tilly. In that patient, it's always going to be quite easy for me, because I'll measure their knee extension take the angle of it, basically. I normally know it, I can normally gauge it, but I take the angle of it, we work at it and I go, there you go, 10 minutes in, we have got your knee nice and straight, or it's a lot straighter than it was. I will make sure that when they stand up, they can get their knee straight, okay? So that's a nice and easy one. But let's say we have a patient that's been doing the right exercises, they're doing it over the right amount of time, but their knee just still isn't going straight. In these instances, I'm always going to check, can I get it? Can I get that knee nice and straight myself, or is there something actually blocking the knee? Now, we need to think what's a true block and what's not really a block, because a lot of people will say cyclops lesion, it's a cyclops, it's a cyclops, it's blocked, but cyclops are rare, okay? They're becoming more common and I'm seeing more and more just because I think people come to me more with problems, but they're not that rare. It often is just really poor rehab and bad habits. But I'm always going to see, can I get it? How much can I get without causing pain to my patient or discomfort? Let's say I can get it. I know it's there, okay? They don't have any reports of any type of front of the knee pain. They don't have any clunking or clicking, although let me tell you something. Out of the cyclops lesions I've seen, probably only 5 of them actually had pain or clunking in the front of that knee. So don't always go off that, because, and even the best of the surgeons will tell you, often cyclops lesion, they don't have a lot of pain at the front of the knee. They don't have the clicking, they don't have the clunking, but what they do have is a true extension lag. So patients come to me, they've got relatively good quads, knee looks generally okay, but they are struggling with that last bit of heel pop. They just can't seem to get it. Then it's just a case of altering the workouts, the routine a little bit, and them having to be a little bit more patient. So first thing I would get my patients to do is really easy. And if I'm a little bit worried that they're really not getting that knee up and they're going to struggle, it's quite stiff, it's quite tight, it's quite rigid, flat back down for me, Matt. I'm going to go under their heel, so I'm going to put them in a slightly little bit of a weighted hang, but not massive. Look, it's a towel, it's tiny, it's certainly not forcing your knee like some therapists do. And what I would do there is say toes to nose for me, Matt, squeeze your quad down as you're going, make sure your bum's not coming off, because this is the biggest mistake people make. You're not even squeezing your quad, you're just squeezing your hip down, which just eventually tries to shove your knee down, but it doesn't work. So toes forward, toes back, squeeze that quad down and hold it. Toes forward, toes back, literally 8 reps. From there, I'm going to move this out of the way, pop it under Matt's leg there, and I'm going to say to him, right, you might not be able to do it. I always say this to all my patients because then they're even more extra determined to do it and prove me wrong. I say you might not be able to do it without the band, but we'll see how you get on. So I'm going to say to Matt, right, just like you did before, first of all, you're going to go toes to nose. That's what I want, because straight away, look at this quad. Look at the knee go down, just toes to nose, drive the knee into the towel. Then I'm going to say, right, from here, can you get a bit of a pop? 9 times out of 10, they can get a pop, trust me. If Matt couldn't get a pop, because some knees are just really tight, the graft's been placed super tight, they don't have any kind of hyperextension anyway, I'll say, right, pop the band around. Now the cues here are absolutely key, and this is exactly what I teach in my ACL recovery guide. You are looking to toes to nose, drive the knee down into that towel for me, Matt, squeeze your quads as much as you can, and for that last bit, allow the band to help you. And then on the down, just drop it, Matt. A lot of people just drop it. They just go up and then bang, just drop. That is not good. You're not going to gain any eccentric control. Eccentric control is the rate that we drop a muscle, okay? Where the most gains can actually be seen in testing. So up you go for me, down for 3 seconds, please. 1, 2, 3, okay? Normally, this drill is enough to give me confidence that that patient doesn't have a cyclops, they can get it, and I'll think, okay, perfect. Then what I will do is get them to stand up and do, just rest Matt, and do banded TKEs and then walk. Can they actually flick that heel? And therapists, you'll know what I mean when I mean flick. Can they flick the heel, land, and actually push off? Does the knee actually go back? This normally will transfer into that with some standing drills. So standing heel rocks, wall knee drive, banded terminal knee extension will normally create a knee that's relatively straight or nearly straight. As long as I see a good level of improvement and they can do it in clinic and I can achieve it in clinic, that will be enough for me to send them home and have a go. But with a cyclops lesion, not to confuse you all, But sometimes you can get this and I'll say to them, okay, stand up for me. They go, yeah, that feels better. I feel like I'm in a better position. Have a walk, do the drills. They just can't. When they walk, they just cannot load that knee. We do the loaded wall knee drive, banded TKEs, they cannot get that knee straight in a standing position. That's when I'm going to be worried. And in that type of patient, I would probably give them 1 week of doing all of my drills properly. And when I say properly, they have to film them and send them to me, and they have to sit in the same position at home every day, morning and night, take a photo from side on so that we can see the amount of daylight closing under their knee. You don't need to be measuring it because it's very difficult to measure your own knee, but at least take a photo in the same position every day, twice a day, so that we can see if that knee is getting closer to the floor and if that heel's starting to pop up a little bit more, and then does it transfer into the gait. If it doesn't, after 1 week, you are going for an MRI scan, because we can see an improvement, but it's nowhere near enough. When you're doing the right exercises prescribed by me, I'm going to be worried at that point because you're not achieving end range knee extension, and it could be that there's some type of scar tissue or cyclops lesion within that knee. So a really simple case, I'm just going to have a little look, have a little feel. Can I get them there? Yep, give them a few exercises. Normally they're there. Some instances when it's 5 or 6 months on, I'll put the complex on. So get a complex muscle stim to really wake up the quads and actually get end range extension, because your quadriceps, when you've been in a fixed flex knee, they can't be fully active. So when people get 6 months down the line and they've been squatting, they've been doing step-ups, but never achieved full knee extension, the quads don't know what full knee extension is. It's not been in that end range position. So we get the complex on and it can really help. Like I said, it's rarely a cyclops lesion. It's more often down to poor rehab. But the biggest problem that I tend to see is clinicians and patients, we're not spotting the difference between the two. So we're not very good at diagnosing a cyclops lesion for sure. And we're equally not very good at diagnosing poor rehab, because what I can tell you is time alone will not improve your knee extension. If anything, it will make it worse. One thing I left out actually is that sometimes if somebody's slightly longer down the line, I will get them to foam roll the hamstring and foam roll the quad, just in case there's a bit of muscle inhibition, a bit of localized tightness, which can sometimes really help for some patients, but is not the biggest tool in my toolkit. The biggest tool is actually doing the right exercises at the right time. And what I want you to take home from this video, if you take home anything, if your therapist is stood forcing your knee session to session, or telling you at home to go into a weighted hang, dangle oven gloves full of beans, you know, get out of it. Find a new therapist. You're not paying 60, 80, 90 quid for that, because it's nonsense. You need to be activating your quads, loading your knee in a capacity that it's happy and can tolerate in order to regain knee extension. Time and forcing it will not work. If you're in either two of those brackets, do you think it's cyclops lesion or is it bad rehab? Best thing I could urge you to do is explore, is it bad rehab, and do a plan that actually works. Whether that's a therapist local to you that's got a proper ACL protocol, or whether you find something like the Complete ACL Recovery Guide, which I will leave in the link below. And step by step teaches you everything just like this and more, and you also get access to me if you've got any queries or questions, video demos for each exercise. I hope you've enjoyed this video. If you have, please drop a like and a subscribe, because it tells me to keep turning up.